Hello everyone, this is Dr. Teresa and we're going to start into the respiratory system. So the respiratory system consists of a system of tubes that deliver air to the lungs. Oxygen diffuses into the blood and carbon dioxide diffuses out. Respiratory and cardiovascular systems work together to deliver oxygen to tissues and remove that carbon dioxide. We consider them together, and when we do that, we call it the cardiopulmonary system. Disorders of the lungs will directly affect the heart and vice versa. The respiratory system and the urinary system, these guys collaborate to regulate the body's acid-base balance. We learned in AMP1 that these guys are our primary buffer systems. So the functions of the respiratory system, again, oxygen and CO2 exchange between the blood and the air. It serves for speech and other vocalizations. It provides a sense of smell. It affects the pH of body fluids by eliminating CO2. It affects the blood pressure by synthesis of angiotensin II. It promotes the flow of lymph in the venous blood and helps expel abdominal contents during urination, defecation, and childbirth. So let's start into the anatomy of the respiratory system. We have the nose, the pharynx, larynx, trachea, bronchi, and lungs. Incoming air stops in the alveoli. These are millions of thin-walled, microscopic air sacs. This exchanges the gases with the bloodstream through the alveolar wall and then flows back out. There's a conducting division of the respiratory system. These are the passages that serve only for airflow and no gas exchange. This would be the nostrils through the major bronchioles. The respiratory division of the respiratory system consists of the alveoli and other gas exchange regions. The upper respiratory tract is in the head and neck. This is nose through larynx, and the lower respiratory tract, the organs of the thorax, which is the trachea, through the lungs. So here we have a picture. We have labeled nose, pharynx, larynx, trachea, bronchi, and lungs. We can see our nasal cavity, the hard palate, which is the roof of your mouth. We also have a soft palate, which is in the back of the mouth, the nostril to the nose, our pharynx, our larynx, our trachea, right and left lungs. We have a pleural cavity. The epiglottis is considered part of this. We see the esophagus, that would be more digestive system. Left lung, left main bronchus, the lobar bronchus, and the segmental bronchus. So the functions of the nose: it warms, cleanses, and humidifies inhaled air, detects odor in the airstream, and serves as a resonating chamber that amplifies the voice. The nose extends from the nostrils or nares to a pair of posterior openings called the posterior nasal apertures, or the conae. The nasal fossa, right and left halves of the nasal cavity. The nasal septum divides the nasal cavity. It's composed of bone and hyaline cartilage. The vomer forms the inferior part. Perpendicular plate of the ethmoids forms the superior part, and the septal cartilage forms the anterior part. The vestibule is the beginning of the nasal cavity. There's a small dilated chamber just inside the nostrils. These guys are lined with stratified squamous epithelium. Vibrissae are stiff guard hairs that block insects and debris from entering the nose. Posteriorly, the nasal cavity expands into a larger chamber with not much open space. It's occupied by three folds of tissue. We call these the nasal conchae. They project from the lateral wall towards the septum. The narrowness and turbulence ensures that most air contacts a mucous membrane. This will clean it and warm it and moisten it. The olfactory epithelium is what detects odor. It covers a small area of the roof of the nasal fossa and the adjacent parts of the septum and the superior conchae. Ciliated pseudostratified columnar epithelium with goblet cells can be found here, and immobile cilia to bind molecules are also included here. Respiratory epithelium lines the rest of the nasal cavity except for the vestibule. Ciliated pseudostratified columnar epithelium with goblet cells will be in here. The cilia here are motile. The goblet cells will secrete mucus, and cilia propel the mucus posteriorly toward the pharynx. It's swallowed then into the digestive tract. In the nose, we have erectile tissue, which is a venous plexus in the inferior concha. Every 30 to 60 minutes, the tissue on one side swells with blood. It restricts airflow through that fossa. Most air is directed through the other nostril and fossa. This allows the engorged side time to recover from drying. The flow of air will shift between the right and left nostril every 1 to 2 hours. So here's another picture of the upper respiratory tract. So we can get an idea. Here's I want you to pay attention here to the sinus cavities. Well, because we hear a lot about sinus infections, right? And we understand how prevalent they are. And we just went through the immune system and how pain and inflammation, all of that comes together. So if you can start putting these concepts together and some of the things that, you know, are a little bit more tangible in your life, I think that'll be easier to understand. Okay, the pharynx, that is our throat. It's the fancy Latin word for our throat. A muscular funnel extending from the conae to the larynx. There are 3 regions of the pharynx. The nasopharynx, which is posterior to the nasal apertures and above the soft palate. It receives the auditory tubes and contains pharyngeal tonsil. It is lined by pseudostratified columnar epithelium. Then we have the oropharynx. This is the space between the soft palate and the epiglottis, and this contains the palatine tonsils. It's lined by stratified squamous epithelium. Then we have the laryngopharynx. This is the epiglottis to the cricoid cartilage. This continues as the esophagus, and it's lined by stratified squamous epithelium. Okay, here we have another representation of that upper respiratory tract, and we can see that nasal septum. We have a perpendicular plate. We have that septal cartilage. There's our vomer bone, if you remember that from Anatomy 1. Then we can see our throat and the pharynx, the nasopharynx, the oropharynx, and then lower is the laryngopharynx. Okay, the larynx. This is our voice box. It's a cartilaginous chamber about 4 centimeters long. Its primary function is to keep food and drink out of the airway. It has evolved to an additional role of phonation, that production of sound. So this helps us speak. The epiglottis, that is a flap of tissue that guards the superior opening of the larynx. During swallowing, the extrinsic muscles of the larynx pull the larynx upward. The tongue pushes the epiglottis down to meet it. This will close the airway and directs food to the esophagus behind it. The vestibular folds of the larynx play a greater role in keeping food and drink out of the airway. So the larynx cartilage. The epiglottic cartilage, it's a spoon-shaped supportive plate in the epiglottis. It's the most superior one. Then we have the thyroid cartilage. This is the largest laryngeal prominence, or that's our Adam's apple, and it is shield shaped. Testosterone stimulates the growth and is larger in males. The cricoid cartilage connects the larynx to the trachea, and it's ring-like. Arytenoid cartilages, there are 2. They're posterior to the thyroid cartilage. The corniculate cartilages, also two, attach to the arytenoid cartilages like a pair of little horns. The cuneiform cartilages support the soft tissue between the arytenoids and the epiglottis. So here we go. This is a picture explaining all of those words. There is our epiglottis, and I think kind of that posterior picture, the one in the middle, might be a little bit easier to see and understand. So we have our epiglottis. That's the flap that will close over the trachea, like when we're swallowing food. We can see our hyoid bone. That thyroid cartilage is our Adam's apple. The midline of that we call the laryngeal prominence. There we have evidence on that posterior aspect of the thyroid cartilage of that arytenoid cartilage and that corniculate cartilage. The corniculate cartilage are the little horns. The cricoid cartilage is that big band at the bottom. And then we can start seeing the rings of tracheal cartilage below that. The interior wall has two folds that extend from the thyroid cartilage to the arytenoid cartilages. The superior vestibular folds, or the false vocal cords, these guys play no role in speech, but they close the larynx during swallowing. The inferior vocal cords are the true cords, and they produce sound when air passes between them. And they contain vocal ligaments. They're covered with stratified squamous epithelium. They produce high-pitched sounds when the cords are taut, and they produce lower-pitched sounds when the cords are more slack. Adult male vocal cords are usually longer and thicker, and they produce lower-pitched sounds. So here's an endoscopic view of the respiratory tract. We can see the epiglottis, we can see the glottis, the vestibular folds on the side, and we can see evidence of a vocal cord. The trachea is the hollow tube, and then the corniculate cartilage, which is covered with some soft tissue. All right, let's talk about the trachea. It's a rigid tube found anterior to the esophagus. It's supported by C-shaped rings of hyaline cartilage. It reinforces the trachea and keeps it from collapsing. Its opening in rings and faces posteriorly towards the esophagus. The trachealis muscle spans the opening in the rings, and the gap in it allows room for the esophagus to expand as swallowed food passes by. It contracts or relaxes to adjust to airflow. The inner lining is ciliated pseudostratified columnar epithelium. It's a mucociliary escalator. It's a mechanism for debris removal. Mucus traps inhaled particles, and the upward beating cilia drives the mucus towards the pharynx where it's swallowed. The middle tracheal layer is connective tissue beneath the tracheal epithelium. This contains lymphatic nodules, mucus and serous glands, and the tracheal cartilages. The adventitia is the outermost layer of the trachea. It's fibrous connective tissue that blends into adventitia of other organs of the mediastinum. Here we have the cilia and the goblet cells. You can see cilia are usually protein microfilaments, or microfilaments, by the way. They're extensions of a cell, right? And that's fascinating how they work and how they are operated by protein mechanisms within the cell membrane. Okay, the lungs. These are conical organs with a broad concave base and a blunt peak called the apex. The hilum, or the root of the lung, is the slit through which the lung receives the main bronchus, blood vessels, lymphatics, and nerves. The right lung is shorter than the left. The liver raises higher on the right, and it has 3 lobes, superior, middle, and inferior, and they're separated by a horizontal and oblique fissure. The left lung is taller, narrower, because the heart tilts toward the left, Has an indentation that we call the cardiac impression, and it has two lobes, superior and inferior, separated by a single oblique fissure. Okay, so here's how they will sit in the thoracic cavity. Due to how they will sit, the right main bronchi, the angle between that and the trachea is a little bit less, so actually it's a little bit more common to get stuff caught down into the right trachea and or lung if anything gets through. We can see that the again, right lung has 3 lobes, horizontal fissure being the uppermost fissure, and then the oblique fissure being the lower one. On that left lung, we can see the cardiac impression where the heart will sit, and the fissure over there is also an oblique fissure, named for the angle. I think that's pretty easy to understand. In the lower view, we're looking at the mediastinal surface of the right lung. We can see the pulmonary arteries, the pulmonary veins. We see the surface. The base of the lung is going to sit right on that diaphragm. And the apex is the point, just like in the heart. We saw the apex of the heart was the pointed portion. Okay, so when we go into the bronchial tree, it's a branching system of air tubes in each lung. From the main bronchus to 65,000 terminal bronchioles. The main or primary bronchi are supported by C-shaped hyaline cartilage rings. The right main bronchus is a branch 2 to 3 centimeters long, rising from the fork of the trachea. The right bronchus is slightly wider and more vertical than the left, which is what I was saying before. So aspirated and inhaled foreign objects lodge in the right bronchus more often than the left. The left main bronchus is about 5 centimeters long. It's slightly narrower and more horizontal than that right. So the bronchial tree, that is the lobar or secondary. There are 3 right lobar or secondary bronchi. There's a superior, middle, and inferior. There's 1 to each lobe of the right lung. And then, correspondingly, there's 2 left lobar bronchi, superior and inferior, 1 to each lobe of the left lung. Then we have a segmental or tertiary bronchi. It's supported by the crescent-shaped cartilage plates, 10 on the right and 8 on the left. So here we have evidence of all of that. We can see the trachea. We can see what we call the carina. That's that middle portion where the fork happens. We see the main bronchi. We see the lobar bronchi, and then the segmental bronchi is that last little branch on that side. Within the tube of the trachea, we can see the lumen and how the cells are arranging. We see a hyaline cartilage, we see the mucosa, we see mucus glands. The bronchial tree, all bronchi are lined with ciliated pseudostratified columnar epithelium. All divisions of the bronchial tree have a large amount of elastic connective tissue. This contributes to the recoil that expels air from the lungs. The mucosa also has a well-developed layer of smooth muscle. Muscularis mucosae contracts or relaxes to constrict or dilate the airway, regulating the airflow. The bronchioles, these guys lack cartilage, 1 millimeter or less in diameter. They have ciliated cuboidal epithelium. They are well-developed layer of smooth muscle and divides into 50 to 80 terminal bronchioles. The final branches of the conducting division, these guys have no mucus glands or goblet cells. They have cilia that will move mucus draining into them back to the mucociliary escalator, and each terminal bronchiole gives off 2 or more smaller respiratory bronchioles. So these respiratory bronchioles, they have alveoli budding from their inner walls. They're considered the beginning of the respiratory division since alveoli participate in gas exchange. They divide into alveolar ducts and they end in alveolar sacs, which are grape-like clusters of alveoli. So the pulmonary alveoli. We've been mentioning the word alveoli, so here we go. we have the bronchiole coming off of the trach. We have a terminal bronchiole, we have a respiratory bronchiole, and this is how it divides and gets smaller. And then we start having these bunches of little like air bubbles or little balloons, and they're heavily wrapped in a capillary network, which makes sense because this is how we're gonna clean the blood. These guys are super important. So those alveoli. Squamous alveolar cells, thin, broad cells that allow for rapid gas diffusion between alveolus and bloodstream. There are also great or type 2 alveolar cells, which repair the alveolar epithelium, and they secrete pulmonary surfactant. This is a mixture of phospholipids and proteins that coat the alveoli and prevent them from collapsing during exhalation. Alveolar macrophages, or dust cells. These are the most numerous of all cells in the lung. These keep the alveolar free from debris. There are 100 million dust cells that perish each day, and they are removed by the mucociliary escalator. Each alveolus is surrounded by a basket of blood vessels that are supplied by the pulmonary artery. The respiratory membrane is the barrier between the alveoli and the blood. The respiratory membrane consists of squamous alveolar cells, endothelial cells of the blood capillaries, and a shared basement membrane. So here we just have an example of the alveoli. We have a great alveolar cell. We have an alveoli macrophage. We can see lymphocytes. We can see the capillary endothelial cell. We can see fluid or the surfactant. We see squamous alveolar cells. Okay, when we talk about the pleura, the visceral pleura, this is the serous membrane that covers the lungs. The parietal pleura adheres to the mediastinum and the inner surface of the rib cage and the superior surface of the diaphragm. The pleural cavity is the potential space between the pleura. Normally, there's no room between the membranes, but it does contain a film of slippery pleural fluid. The functions of the pleura and the pleural fluid, this is to reduce the friction because there's constant movement and create a pressure gradient. The lower pressure than atmospheric pressure. This assists in the lung inflation. Compartmentalization, this prevents the spread of infection from one organ in the mediastinum to the other. So the pleura of the lungs is hugely important on more than just a friction level. Okay, so pulmonary ventilation, let's talk about that. Breathing is what we call pulmonary ventilation. It consists of a repetitive cycle. One cycle of inspiration or inhaling and expiration or exhaling. The respiratory cycle is one complete inspiration and expiration. Quiet respiration happens while at rest. It's effortless and automatic. Forced respiration is deep, rapid breathing, such as during exercise. The flow of air in and out of the lungs depends on a pressure difference between air pressure within the lungs and outside the body. Breathing muscles change lung volumes and create differences in pressure relative to the atmosphere. And as usual, I can't get that guy to work, so that is okay. Okay, so the diaphragm. This is the prime mover of respiration. The contraction flattens the diaphragm, enlarging the thoracic cavity, and pulling air into the lungs. Relaxation of the diaphragm allows the diaphragm to bulge upward again, compressing the lungs and expelling air. Internal and external intercostal muscles. These guys are synergistic to the diaphragm. They stiffen the thoracic cage during respiration. They contribute to enlargement and contraction of the thoracic cage, and they add about 1/3 of the air that ventilates the lungs. Normal quiet expiration is an energy-saving passive process, and it's achieved by the elasticity of the lungs and the thoracic cage. As the muscles relax, the structures recoil to their original shape and original size of the thoracic cavity and results in the airflow out of the lungs. A forced expiration will employ the rectus abdominis, the internal intercostals, and other lumbar, abdominal, and pelvic muscles. This is greatly increased abdominal pressure pushes the viscera up against the diaphragm, increasing the thoracic pressure, forcing air out. So here's a great picture for the muscles of respiration. We can see we have, okay, on the left side of the picture, we can see the muscles when we're talking about like an inspiratory process. There are some accessory breathing muscles that I think are really important for you to understand. That's the SCM, or the sternocleidomastoid, which will help elevate the sternum, and also the scalenes, which are fixed to some of your ribs. They elevate ribs 1 and 2. We have the external intercostals that elevate ribs 2 through 12 and widen the thoracic cavity. We have the pec minor, which elevates ribs 3 through 5. We have an internal intercostalis, an intercollagenous part that aids in elevating the ribs as well, and then of course the diaphragm. On forced expiration, we have the internal intercostals, the interosseous part. This will help depress the ribs 1 through 11 and narrows the thoracic cavity. Again, that diaphragm. Then the rectus abdominis and the external abdominal oblique will help depress and lower ribs. So in inspiration, we're lifting the rib cage up. Pay attention to muscular tenderness of rib muscles and sternocleidomastoid and scalenes, the neck muscles. You can tell a lot about how a person is breathing, if they are actually breathing well, or if they are employing more of the accessory muscles of breathing, which again would be the SCM and the scalenes. Okay, so Valsalva's maneuver. This is consistent of taking a deep breath, holding it by closing the glottis and then contracting the abdominal muscles to raise the abdominal pressure and push the organ contents out. This happens in childbirth, urination, defecation, and vomiting. So this is one method to see, or that is used oftentimes to determine, honestly, spinal lesions. Okay, if it's a pain-creating thing, we do a false Valsalva's maneuver, or a performed Valsalva's maneuver. Okay, the neural control of breathing. There's no autorhythmic pacemaker cells for respiration like there is in the heart. The exact mechanism for setting the rhythm of respiration is unknown. It's another one of those things we still do not have figured out. Breathing depends on a repetitive stimuli of skeletal muscles from the brain, and neurons in the medulla and pons control unconscious breathing. So let's look at some of the respiration centers. If we look, we have spinal cord centers. The pons is involved. There's a hypothalamic portion to this as well. We have limbic systems and higher brain centers involved. So we're going to have emotions involved in breath. The voluntary control originates in the motor cortex of the frontal lobe of the cerebrum. The fibers of the phrenic nerve will supply the diaphragm. The intercostal muscles, intercostal nerves will supply the intercostal muscles. There are limits to the voluntary control. There's a breaking point when the CO2 levels rise to a point when automatic controls are overridden by one's will. 3 pairs of respiratory centers are in the medulla and the pons, and these control that automatic rate during quiet respiration. We have some brainstem respiratory centers. The respiratory nuclei in the medulla. This is the ventral respiratory group, or VRG, and this is a primary generator of the respiratory rhythm. It produces a respiratory rhythm of 12 breaths per minute. The dorsal respiratory group, or DRG, modifies the rate and depth of breathing. This receives influences from external sources. The pons, we have a pontine respiratory group, or PRG. This modifies the rhythm of the VRG. This adapts breathing to special circumstances such as sleep, exercise, vocalization, and emotional responses. So we have central chemoreceptors. These are brainstem neurons that respond to changes in pH of cerebrospinal fluid. By regulating respiration to maintain a stable pH, the respiratory centers also ensure stable CO2 level in the blood and the CSF. The peripheral chemoreceptors that are located in the carotid and aortic bodies and the large arteries above the heart, remember those, they respond to O2 and CO2 content and the pH of the blood. Then we have stretch receptors that are found in the smooth muscles of the bronchi and the bronchioles and in the visceral pleura. They respond to inflation of the lungs. We have irritant receptors. These are nerve endings amid the epithelial cells of the airway. They respond to smoke, dust, pollen, chemical fumes, cold air, and excess mucus. They trigger protective reflexes such as bronchoconstriction, shallower breathing, and breath holding or coughing. Airflow is governed by principles of flow, pressure, and resistance. Atmospheric pressure drives respiration. The weight of the air above us has a lot to do with how we breathe. 760 millimeters of mercury at sea level or 1 atmosphere. These are, and it's lower at the higher elevation. So if you've ever been, like for instance, in Colorado, up in the Rocky Mountains, you can get like an altitude sickness, and you breathe differently due to the partial pressure of oxygen at higher levels. Boyle's law: at a constant temperature, the pressure of a given quantity of gas is inversely proportional to its volume. If the lungs contain a quantity of a gas and the lung volume increases, their internal pressure or the intrapulmonary pressure falls. If the pressure falls below atmospheric pressure, the air moves into the lungs. If the lung volume decreases, intrapulmonary pressure rises. If the pressure rises above atmospheric pressure, the air moves out of the lungs. Okay. Here's an example. I'm not going to read this slide to you. You guys can swing through this and look at how we have the respiratory cycle happening in regards to atmospheric pressure and diaphragm influence in accordance with that. The intrapleural pressure, this is a slight vacuum that exists between the two pleural layers. Some of this pressure change transfers to the interior of the lungs. The ribs swing upward during inspiration and parietal pleura follows. The visceral pleura clings to it by the cohesion of water and it follows the parietal pleura. It stretches the alveoli within the lungs. The entire lung expands along the thoracic cage. As it increases in volume, its internal pressure drops and air flows in. Charles' law: this is the given quantity of a gas is directly proportional to its absolute pressure. On a cool day, air will increase its temperature by 21 degrees during inspiration. Inhaled air is warmed to 37 degrees by the time it reaches the alveoli. And the inhaled volume of 500 milliliters will expand to 536 milliliters, and this thermal expansion will contribute to the inflation of the lungs. When we have relaxed breathing, this is a passive process that's achieved mainly by the elastic recoil of the thoracic cage. The recoil compresses the lung. The volume of thoracic cavity decreases. It raises intrapulmonary pressure. Air flows down the pressure gradient and out of the lungs. When we have a forced breathing situation, the accessory muscles raise intrapulmonary pressure even further. There are massive amounts of air that can move out of the lungs with forced breathing. Okay, pneumothorax is the presence of air in the pleural cavity. The thoracic wall gets punctured in this case. Inspiration sucks air through the wound into the pleural cavity. The potential space becomes an air-filled cavity. The loss of negative intrapleural pressure allows the lungs to recoil and collapse. Atelectasis is the collapse of a part or all of a lung. This can also result from an airway obstruction. So when we're talking about resistance to airflow, the greater the resistance, the slower the flow. There are three main factors that influence airway resistance, and this is similar to blood pressure. It's the diameter of the bronchioles. Bronchodilation increases in the diameter of a bronchus or bronchiole. Epinephrine and sympathetic stimulation stimulate bronchodilation and increase airflow. When we have bronchoconstriction, this is the decrease in the diameter of the bronchus or bronchiole. An example would be histamine production, parasympathetic nerves, cold air, and chemical irritants that stimulate bronchoconstriction. Suffocation from extreme bronchoconstriction is brought about by anaphylactic shock and asthma. Pulmonary compliance. This is the compliance reduced by degenerative lung diseases in which the lungs are stiffened by scar tissue. Surface tension of the alveoli and distal bronchioles. This is surfactant will reduce the surface tension of the water. This is produced by the great alveolar cells. Infant respiratory distress syndrome, or IRDS, in premature babies is a result of this. So, alveolar ventilation. Only air that enters the alveoli is available for gas exchange. There's about 150 milliliters that fills the conducting division of the airway. There's anatomic dead space, the conducting division of an airway where there's no gas exchange. In pulmonary diseases, some alveoli may be unable to exchange gases because they lack blood flow, or respiratory membrane has been thickened by edema or fibrosis. Physiologic dead space or total dead space. This is the sum of the anatomic dead space and any pathological alveolar dead space. A person inhales 500 milliliters of air and 150 milliliters can stay in anatomical dead space. Then 350 can actually reach the alveoli. So when we're talking about respiration rates, the AVR, or alveolar ventilation rate. This is the air that ventilates the alveoli times the respiratory rate. Okay, so we have 350 milliliters times the respiratory rate, 12 beats per minute, equals 4,200 milliliters per minute. The residual volume is 1,300 milliliters that cannot be exhaled with maximum effort. Spirometry. This is the measurement of pulmonary function and aids in the diagnosis and assessment of restrictive and obstructive lung disorders. A spirometer is a device that recaptures expired breath. When we're talking respiratory volumes, we have tidal volume. This is the volume of air inhaled and exhaled in one cycle during quiet breathing and should be about 500 milliliters. The inspiratory reserve volume. This is the air in excess of tidal volume that can be inhaled with maximum effort and can be around 3,000 milliliters. Expiratory reserve volume, this is the air in excess of the tidal volume that can be exhaled with maximum effort, and that's around 1,200. Residual volume is the air remaining in the lungs after maximum expiration. The vital capacity is the total amount of air that can be inhaled and then exhaled with maximum effort. So we have an equation that's going to be important. I would take note of this. It's an important measure of pulmonary health. We have VC equals ERV plus TV plus IRV. The inspiratory capacity is the maximum amount of air that can be inhaled after a normal tidal expiration. The functional residual capacity is the amount of air remaining in the lungs after the normal tidal expiration. Total lung capacity, maximum amount of air of the lungs that contain, or the maximum amount of the air the lungs can contain. Okay, the variations in the respiratory rhythm. We have eupnea, which is relaxed, quiet breathing. This is characterized by tidal volume of 500 milliliters and the respiratory rate of 12 to 15 beats per minute. Apnea, temporary cessation of breathing. Dyspnea, labored, gasp, breathing or shortness of breath. Hyperpnea, increased rate and depth of breathing in response to exercise, pain, or other conditions. Hyperventilation, increased pulmonary ventilation in excess of metabolic demand. Hypoventilation is the reduced pulmonary ventilation. Kussmaul respiration, deep, rapid breathing, often induced by acidosis. Orthopnea, dyspnea that occurs when a person is lying down. Respiratory arrest is the permanent cessation of breathing, and tachypnea is accelerated respiration. Okay, so let's get into the composition of air. Dalton's law, the total atmospheric pressure is the sum of the individual gases. So partial pressure, the separate contribution of each gas in a mixture. At sea level, 1 atmospheric pressure equals 760 millimeters of mercury. Nitrogen constitutes 78.6% of the atmosphere. Thus, the partial pressure of nitrogen is 597 of that 760. The partial pressure of oxygen is only 159. Isn't that interesting? Then we have water and CO2 in it as well. The composition of inspired air and alveolar is different because of 3 influences. Air is humidified by contact with mucous membranes, so the alveolar partial pressure of water is more than 10 times higher than inhaled air. Freshly inspired air mixes with residual air left from the previous respiratory cycle. Oxygen then is diluted and is enriched with CO2. Alveolar air exchanges O2 and CO2 with the blood. So the pressure of oxygen of alveolar air is lower at 13% than the atmosphere, which is 20. And then the pressure of CO2 is more than 130 times higher in the alveoli. So the alveolar gas exchange, the back and forth traffic of O2 and CO2 across those respiratory membranes. For oxygen to get into the blood, it must pass through the respiratory membrane, through the cell of the alveoli, basement membrane, then endothelium. For carbon dioxide to leave the blood, it must pass in the other direction, through the endothelium, basement membrane, then the alveoli of the cell. The greater the pressure of oxygen in the alveolar air, the more O2 the blood picks up. Since the blood arriving at the alveoli has a higher PCO2 than air, it releases CO2 into the air. Each gas in a mixture will behave independently. That's Henry's law. So one gas does not influence the diffusion of the other. Gases we're talking diffusion, so they're going to flow down the pressure gradient. The pressure of oxygen at 104 millimeters of mercury in alveolar air versus 40 millimeters in the blood. PCO2 46 millimeters in the blood arriving versus 40 in the alveolar air. Hyperbaric oxygen therapy. This is the treatment with oxygen at greater than 1 atmosphere pressure. There's a bigger gradient, more O2 gets delivered to the blood. At high altitudes, the pressure is lower. Like I said, the pressure gradient is less oxygen. So it's a smaller gradient and there's less oxygen into the blood. So some conditions that will impact gas exchange. The membrane surface area. Emphysema, lung cancer, and TB decrease the surface area for the gas exchange. The thickness of the membrane will impact it. Pulmonary edema in the left ventricle and left ventricle failure causes edema and thickening of the respiratory membrane. Pneumonia causes thickening of respiratory membranes. Ventilation, perfusion, coupling. This is the ability to match ventilation and perfusion to each other. So gas exchange requires both good ventilation of alveolus and good perfusion of the capillaries. Diseased lung tissue no longer receives alveolar blood flow because it is not performing adequate gas exchange. So gas transport. This is the process of carrying gases from the alveoli to the systemic tissues and back. Oxygen transport, 98.5% is bound to the hemoglobin, 1.5 is dissolved in the plasma. Carbon dioxide transport, 70% of it is as bicarbonate ion. 23% is bound to hemoglobin, and 7% is dissolved in plasma. So hemoglobin is a protein specialized in oxygen transport. It has four globin portions, each with the heme group, which binds one oxygen to the iron, the Fe2. One hemoglobin molecule can carry up to 4 oxygen. Oxyhemoglobin, or O2 bound to hemoglobin, is what we call that. Deoxyhemoglobin is hemoglobin with no oxygen. 100% saturation hemoglobin with 4 O2 molecules, or 50% saturation of hemoglobin with 2 O2 molecules. Carbonic acid, 90% of carbon dioxide is hydrated to form carbonic acid. Remember this equation. CO2 plus water is carbonic acid, which can be broken down into bicarbonate and hydrogen. Carb-aminohemoglobin is 5% binds to hemoglobin. Carbon dioxide does not compete with oxygen. It binds to different places on the hemoglobin. Hemoglobin can transport O2 and CO2 simultaneously. 5% is carried in the blood as dissolved gas. Carbon monoxide poisoning. The danger here is it does compete for oxygen binding sites. It's colorless, odorless, in cigarette smoke, engine exhaust fumes from furnaces and space heaters. It binds 210 times as tightly as oxygen. It ties up hemoglobin for a long time. For non-smokers, less than 1.5% of hemoglobin is occupied by CO2. For smokers, 10% is. That's in heavy smokers. Atmospheric concentrations of 0.2% of carbon monoxide is quickly lethal, so it doesn't take much. Okay, the rate and depth of breathing adjust to maintain the levels of pH, the pressure of carbon dioxide, and the pressure of oxygen. So the brainstem respiratory centers receive input from central and peripheral chemoreceptors that monitor the composition of blood and the CSF. The most potent stimulus for breathing is pH, and it's followed by CO2, and the least significant is O2. Pulmonary ventilation is adjusted to maintain the pH of the brain. The central chemoreceptors. The CO2 crosses into the CSF, reacts with water, and produces carbonic acid. This dissociates into bicarbonate and hydrogen ions. Most of the hydrogen remains free and greatly stimulates the central chemoreceptors. Hydrogen ions are also a potent stimulus to the peripheral chemoreceptors. So acidosis is when that blood pH drops lower than 7.35. Alkalosis is higher than 7.45. Hypocapnia is that pressure of CO2 is less than 37. It's the most common cause of alkalosis. Hypercapnia is that pressure of CO2 is greater than 43, and it's the most common cause of acidosis. So respiratory acidosis is a pH that's over 7.35. It's a mismatch between pulmonary ventilation and CO2 production. Hyperventilation is a corrective hemostatic response to acidosis. It's the blowing off CO2 faster than the body produces it. It pushes the reaction to the left, actually, and builds up the CO2. It reduces the acid, but it raises the blood pH to normal. So when we have respiratory alkalosis, that's when we have a pH lower than 7.45. It's hypoventilation as a corrective homeostatic response to alkalosis. So it allows the CO2 to accumulate in the body fluids faster, and we exhale it. And again, that shifts that buffering equation in the normal direction, raising the acidity level a little bit. So the pressure of oxygen usually has little effect on respiration. Chronic hypoxia, that's a partial pressure of oxygen less than 60 millimeters of mercury, can significantly stimulate ventilation. This is what we call hypoxic drive, and the respiration is driven more by low PO2 than by CO2 or pH. This can happen in emphysema or pneumonia or high elevations. When we talk about respiration and exercise, this causes of increased respiration during exercise. When the brain sends motor commands to the muscles, it also sends this information to the respiratory centers. It increases pulmonary ventilation in anticipation of the needs of exercising muscles. Exercise stimulates proprioceptors of the muscles and joints, and it transmits excitatory signals to the brain's stem respiratory centers. There's an increase in breathing because the muscles have been told to move or are actually moving. Okay, so hypoxia is a deficiency of oxygen in a tissue or the inability to use oxygen. Cyanosis is an example of this. This is when we turn blue. Turning blue, that color, cyanosis, is a sign of hypoxia. Hypoxemic hypoxia, this is a state of low arterial oxygen pressure. It's usually due to inadequate pulmonary gas exchange and oxygen deficiency at high elevations, impaired ventilation, drowning, aspiration of a foreign body, respiratory arrest, or degenerative lung diseases can create this. And then there's something called ischemic hypoxia. This is inadequate circulation of blood, like in congestive heart failure. Anemic hypoxia is due to anemia resulting from the inability of the blood to carry adequate oxygen. Histotoxic hypoxia is a metabolic poison, such as cyanide, that prevents the tissues from using oxygen that gets delivered to them. Chronic obstructive pulmonary disease, or COPD, is any disorder with a long-term obstruction of airflow and reduction in pulmonary ventilation. Major COPDs are chronic bronchitis and emphysema, and usually associated with smoking. Other risk factors, though, include air pollution or occupational exposure to airborne pollutants or irritants. Chronic bronchitis is the inflammation and hyperplasia of the bronchial mucosa. The cilia are immobilized and reduced in number. Goblet cells enlarge and produce excess mucus. They develop chronic cough to bring up extra mucus. Sputum is formed. This is mucus and cellular debris. This is ideal growth for media for bacteria. It incapacitates alveolar macrophages. So this leads to a chronic infection and bronchial inflammation. The symptoms will include dyspnea, hypoxia, cyanosis, and attacks of coughing. Emphysema. Alveolar walls will break down. The lung has a larger but fewer alveoli and much less respiratory membrane for gas exchange. The lungs are fibrotic and less elastic. Healthy lungs are like a sponge, and emphysema lungs are more like a rigid balloon. The air passages collapse. They obstruct the outflow of air, and air gets trapped in the lungs. So the consequences of COPDs. This reduces pulmonary compliance and vital capacity. Hypoxemia, hypercapnia, respiratory acidosis. These are hypoxia stimulates the erythropoietin release from the kidneys and leads to polycythemia. Cor pulmonale, this is hypertrophy and potential failure of the right heart due to obstruction of the pulmonary circulation. So smoking and lung cancer. Lung cancer accounts for more deaths than any other form of cancer. Most important cause is contributed to by smoking. There's 15 carcinogens in it. Squamous cell carcinoma is the most common. It begins with the transformation of bronchial epithelium into stratified squamous from ciliated pseudostratified epithelium. The dividing cell invades the bronchial wall, causes bleeding lesions, and then there's a dense swirl of keratin that replaces functional respiratory tissue. Adenocarcinoma, this originates in the mucus gland of the lamina propria. Then we have small cell or oat cell carcinoma. This is the least common but the most dangerous. It is named for the clusters of cells that resemble oat grains. It originates in the primary bronchi and invades the mediastinum. It metastasizes quickly to the other organs. 90% originate in the primary bronchi. The tumor invades the bronchial wall, compresses the airway, and may cause atelectasis. Often it's the first sign is coughing up blood. Metastasis is rapid, and it usually occurs by the time of diagnosis. Common sites are the pericardium, heart, bones, liver, lymph nodes, and brain. The prognosis is poor after the diagnosis, and only 7% of patients survive 5 years. So here is an example of a healthy lung at the mediastinal surface. And then we have a smoker's lung with carcinoma. All right, gang, that was our respiration chapter, and I hope that was helpful.